FM. Joy 99.7 FM. Joy 99.7 FM.
Ultimate Health on Joy 99.7 FM. We're live on Facebook, YouTube, and X.
Joy 99.7 FM.
Team Eternity there. Defe.
Joy 99.7 FM. Joy 99.7 FM.
All right, great intro. We're in great hands. Ultimate Health on Joy 99.7 FM. Last week we started Conception 2025. How to get pregnant safely. Our guest consultant obstetrician gynecologist with Elimas Health, Dr. Paddy Ayete, is with us on Zoom, I believe. Doc, can you hear me?
I can hear you. Can you hear me?
I can hear you loud and clear. How's your Sunday?
Oh, it's been good. It's been a quiet, peaceful Sunday, which is the way it's supposed to be.
Okay, great stuff. Last week we had tons of feedback. We tried to basically explain certain things that have to be checked, have to be in place if anybody plans to get pregnant intentionally. Right? But Doc, interestingly, just in the space of the week, I done some research on the percentage, the prevalence of unplanned, unintended, what's the other word? Missed.
And what did you find?
Wow, over 47% of
half of all pregnancies are not planned.
Up to 4, or what?
I said half of all pregnancies are not planned.
Right. And there were interesting factors and risk variables that increase the likelihood that a pregnancy may be unintended, mistimed, unplanned. Marital status being one of them. Age being one of them. Access and quality of reproductive health care being one of them, poverty and many other things. Are there any you would like to add?
Well, no, generally, those are the major things. I think people when they're having sex are not thinking about, hey, can I ensure that I don't get pregnant now because I'm not ready? And then for those who are trying to get pregnant, they tend to be more purposeful. We want to get pregnant now. Some of them will come up and say, I want to come and do a test, but quite a number of them, like they are trying to get pregnant. We've been trying for a couple of months, not coming, and they are the ones who end up coming to hospital. But for quite a number of them, it's, we're just having a bit of fun, or, so something just happened, and then they got pregnant.
Okay. So
the younger people tend to think that, it can't happen just like that. Or those that, this week I got somebody who said, every time I need to get pregnant, you give me medicine so I get pregnant. So I didn't think I would get pregnant on my own. Well, she got pregnant on her own this time.
Okay. So these are important things we need to look at. The age of persons who plan or don't plan to get pregnant, their access and the quality of reproductive health care services, even access and quality of contraceptive, interventions, and many other things. Education was another key one, right? So these are important things that we need to know. But another thing I discovered, Doc, was that unintended pregnancies increase the chances of complications or untoward outcomes.
Indeed, that is indeed the case.
Right. The fact that you didn't intend to, right? You didn't
Yes.
plan to, increases the chances that many things may have been overlooked, ignored,
Yeah.
and therefore increase the chances of complications or untoward outcomes.
Precisely so. So those who are planning to get pregnant, they kind of want to seek information to see what do I need to do to make my chances good,
Okay.
and they would deliberately take the steps that we need to take. The whole preconception care business.
Okay.
They would ensure that okay, I'm in the best possible health to ensure that I have a good outcome. For those who don't intend to get pregnant, because they were not intending to get pregnant, they didn't go through that process of let me prepare myself to get a good outcome. And next thing they know, before you are aware, they are indeed pregnant.
Okay.
And then it then comes to chasing after the fact.
Okay.
They are now trying to fix problems that were better fixed before you got pregnant, but now you're already pregnant, so they are playing catch up.
Okay.
The result, of course, is that those kinds of people tend to have more complications.
All right.
For example, if you are in an early stage of diabetes and if you run some tests, we see that you have it, we are like, okay, fix her sugar levels, get everything back under control before she gets pregnant. That person is less likely to have diabetes in pregnancy than somebody who has already elevated parameters and then she gets pregnant. But pregnancy tends to predispose you to diabetes anyway.
Okay.
Hypertension to the same thing. If your blood pressure is not under control before you get pregnant, you have crisis, and you have crisis very early.
Okay.
You may not be able to see the end of the pregnancy because of your existing blood pressure. So these are just two examples of things that you can fix.
Okay.
If only you intended to get pregnant.
All right. So can we hit that button again and go over what we meant and what the objectives of preconception consultation, seeing or booking an appointment with your healthcare provider and going through the steps based on the fact that you do intend to get pregnant. We introduced this and we did quite some work last week, but can we just quickly go over that for our listeners? And then again, underscoring that those who did not intend to may miss this important step in achieving conception.
Yeah, so when it comes to preconception care or counseling, essentially the objective is for you to have a visit with your healthcare provider where you discuss your plans of getting pregnant and then receive the certain interventions that will put in place to ensure that you have a good pregnancy.
Okay.
That is the plan and that's the intention. However, we as obstetricians or gynecologists, let's say gynecologists, or even your general practitioner who sees you regularly, like this is 2025. One of the questions that we are supposed to ask is, do you intend to get pregnant this year? Because she may not raise it.
Okay.
But once you ask that question, she may think about it and say, yeah, I wouldn't mind getting pregnant this year. Then you can say, let's go ahead and do the things that we have to do.
Okay.
The objective is to help you to get through your pregnancy safely, to keep you and your baby as healthy as possible, to reduce child mortality and maternal mortality as well, prevent complications during pregnancy and during delivery, to prevent stillbirths, preterm labor, and preterm birth, prevent low birth children, reduce neonatal infections because the infections that the baby can get either from the mother or just after it's born, and prevent the transmission of STDs or HIV, and prevent the transmission of genetic disorders. We shouldn't forget that part.
Okay.
So essentially, you go to the hospital, and the doctor's first job is, what is your degree of risk? We are trying to find out. You ask questions about your medical history, your surgical history, your family history. We ask about your partner's medical history, his family history as well.
Okay.
We are looking for conditions that may exist amongst your family members that we start looking for in you if you are at risk.
Okay.
We look at your dining history, lifestyle factors, diet, tobacco use, alcohol use. We look at exposure to environmental toxins, asbestos, lead, pesticides, workplace chemicals, things of that sort. And then we may do a physical examination in an attempt to try and find out what exactly it is that you are encountering.
Okay.
During a physical examination, we are looking at your heart, we are looking at your lungs, we are looking at blood pressure, maybe a pelvic exam, and then we run some tests. We are looking for infections, including cervical cancer or the HPV virus, and then genetic testing for things like the commonest thing we have in our part of the world is sickle cell.
Sickle cell, right?
If you are AS and she's AS, and the man is AS and the woman is AS, you have a 1 in 4 chance of having an SS child. The challenge is that it is a 1 in 4 chance. That does not mean that if you have 4 children, only one of them will be SS.
Okay.
All 4 can be SS because each time you try and get pregnant, you have a 1 in 4 chance of getting pregnant.
Right. Okay.
Those things are supposed to be dealt with at counseling times. But sometimes those who don't go through that process are having dealt with that situation. Those who are having casual sex are not thinking about the fact that they may get pregnant. They don't have that opportunity to have that intervention.
Okay.
However, an option that exists for them, you can actually do genetic screening for embryos if you are doing an IVF. And therefore, you can pick the embryo that doesn't have the SS gene. So before there was no hope, now there is some hope of something that we can do to fix.
All right.
And then once you've seen all that, you plan your interventions. If the person is on medications, you want to adjust the medications. If you are hypertensive, you want the hypertension to be under control, the diabetes under control. If you have got asthma, depression, heart disease, all those things, kidney disease, thyroid disease, we try and get them all under control before you actually get pregnant. And then we put you on medications for the baby. If your HB is low, we put you on iron. But most importantly, we put you on folic acid because they prevent neural tube defect. Now, this visit should be at least 3 months before you intend to get pregnant, and our treatment should be like maybe 3 to 6 months before you actually get pregnant.
Okay.
So there's quite a lot of things that have to be done. Then you look at diet, exercise, weight adjustment if need be, and then if you are smoking, we'll tell you to stop. If you are drinking alcohol, we'll tell you to stop. If your weight is too big, we'll help you to reduce your weight, stuff like that.
Okay. All right. Great. If you've just joined us, 23 minutes past the hour of 2 on Joy 99.7 FM. The program every Sunday afternoon, 2 to 3, is Ultimate Health, your ultimate guide to healthy living. With me, Nortey by nature. My guest, Dr. Padiaite, is the consultant obstetrician gynecologist, specialist in minimally invasive surgery. He's the CEO of Elimas Health, and he's also the medical director. They are located in the airport residential area and also in Tema Community 18 near, I believe, is it the Block Factory Junction? It's a green and white building,
Building.
Yeah, multi-story building. Okay, so Doc, having gone through that, and I know you started unpacking some of the things we'll go through, we'll be looking at, is there a checklist? Is there a basic list of things that your provider, even at the pre-specialist level, needs to take you through once you've indicated that you want to get pregnant? We stick to 2025 as our index year. You want to get pregnant this year. What should your pre-conception consultation involve, and what are the kind of steps? We'll go through that. But may I ask, I mean, even though we're going to do pre-conception consultation and all that, is there any situation, any circumstance where you may find yourself having to, give your professional advice concerning the risks and therefore the fact that a person or a couple cannot or should not conceive or try to get pregnant? Is there any circumstance like that where you've gone through certain things and you are able to tell them that, well, this is not a good idea? I know there are many other ways of, assisted reproduction, but does that arise?
Yes, there are locations that I've had to tell somebody that I don't think it's a good idea to have a child. Two of them notably come to mind. One of them, they went ahead to have the child, and she survived. And the mother survived. The mother had a heart condition.
Okay.
And we're really concerned about the fact that the heart may not be able to withstand the stress of pregnancy.
Okay.
The other one had a significant kidney problem, and she was also an older client. So I was like, if I'm combining her age plus the ability to carry and then the stress it would put on her renal system, I was not convinced that she would successfully carry the pregnancy to term. And it may jeopardize her renal system to the extent that may put her in renal failure. So it wasn't, we had a discussion that it wasn't going to be a good idea. In her case, she was looking for an intervention, and usually the body would, if your system is not very well, you wouldn't get pregnant.
Okay.
It will find a way to sabotage you. But if you are doing an IVF and things for you, we are going around those methods it can use to sabotage you. So you may actually succeed in getting pregnant after those interventions.
Okay.
So that is why we need to do the assessment to say, I don't think this may be a good idea. But you can offer those people surrogacy, because if somebody else carries for them, their medical risk no longer exists.
Okay.
So it is possible to to, even if they are not supposed to carry a pregnancy, it is possible for them to have a child if we use other methods. So it's not a zero sum that you cannot have a child at all. It is, maybe we will say you cannot carry the child because of your medical condition. I've had patients there's a patient that we had that had severe, that's several years ago in Kolebu, severe hypertension, extreme crisis. And I mean, she shouldn't have gotten pregnant in the first place. She didn't get pregnant. The blood pressure was extremely high. I mean, just in the 200s. And I recall we were doing her best to try and manage it. Then there was a discussion about terminating it. It was up and down and up and down. Then her child got assaulted at home. So then that added more crisis onto this. It was just crazy. So there are some pretty challenging circumstances.
There are challenging circumstances where you would not advise a person or a couple to, should I say, attempt to get pregnant. And though there are ways around it. But interestingly, Doc, you mentioned that there was one instance where you gave this advice and the person overruled you.
Yeah, she did. She went ahead and had a child. And she survived. It's not like you're not,
So despite the risk, the person went ahead.
We look at the risks and tell you we don't think it's a good idea because you put your heart in danger. And she was like, I really want to have this child. And so she went ahead and got pregnant. And carried the pregnancy to term. That's the kind of pregnancy that you and the cardiologist, the obstetrician and the cardiologist have to be good friends because they'll be discussing that patient every day.
Now, Doc,
and you end up delivering her in a cardiac center, even though she's not a cardiac patient.
So the circumstances
at that time,
and the situation of the delivery even changed because of these circumstances.
Yes, because of the circumstance. What's the concern? You can do a delivery easily, but can the heart withstand it? So you say, okay, you end up doing a cesarean section, and because of a pre-existing cardiac disease, you end up doing it in a cardiac center, so that if the cardiac crisis occurs, they can intervene immediately in their space. And then you just pick up the baby and you run away.
Let me also ask, Doc, I mean, let's say as I'm listening to you now, I have found out, and I do believe I'm pregnant. Do I still need to backpedal and come to you and go through all these checks? I mean, you said at least 3 months prior to getting pregnant. But here I listened to Nortey and you this Sunday, 19th of January, and I do a test and I find I am already pregnant. Do I still need to come see you, or should I?
As soon as possible.
I've already conceived. Can I
assume? As soon as possible.
I cannot and should not assume I'm okay.
This is not the case where you'd say, "Oh, let me wait until the pregnancy has grown small." You know those olden days people. They're like, "Oh, but I was training Gina Kakran Sawak Hospital." That
you should still.
The moment you discover you are pregnant, come. Especially if you know you haven't tested for these things. Because in the case of prevention of mother-to-child transmission, in the event that we do a test and discover that you are HIV positive, our immediate focus is don't let that baby get it. We can worry about the mother and manage the mother, but that baby shouldn't get it. It's an additional stress on the mother, and we must do our best to avoid it. So for that reason, you want to know very early so they can start her treatment very early so the baby doesn't get exposed to it, and then she can give birth to a normal, healthy baby that we don't have to worry about. So that all we have to be managed now is the mother. Ectopic pregnancies. The pregnancy can occur in the wrong place, in the tube. If anybody has a ruptured ectopic, invariably, it means that she didn't go to hospital early enough or it was not picked. Which sometimes they can really hide in some very dangerous places. But most of the time, if you go to the hospital between by your 6th week, we should be able to see that the pregnancy is in the right place with the heart beating. Latest 7 weeks. If you can't find it by 7 weeks, we know that we have a problem on our hands.
I know I have several of the stubborn academies clan online listening to us. They probably think, well, Doc is going to charge me some significant amount of money. I'm already pregnant. That shows my system works. I'm okay. So I probably will ignore, or I am not part of the subset of people that Nortey is saying and suggesting alongside his qualified resource person should present themselves for preconception counseling. Even though you have achieved that conception, is it in the right place? Is it developing or progressing normally and all that? So we need to quickly get into that. Let me just read a couple of messages. If you can switch for me, Ziggy. We're talking to Dr. Paddy Ayete, consultant obstetrician gynecologist. He's a specialist in assisted reproductive strategies or techniques. He's also a specialist in minimally invasive surgery. He's the medical director of Elimas Health. This one says, "Good afternoon, Nortey. Welcome to my home. This is from Oye in Afienya. Okay, we're glad to be in your home, but we have to come there physically. We keep on saying this. We'll try and make that happen." Do I have another one? Nope. It's only that from, okay, this is somebody else talking about food in SHS. If you want to send a WhatsApp is 055 11 11 997. I will activate the phone line 030 221 6541. We are continuing our discussion as part of our determination to achieve conception, at least for those who plan to, intend to, are in committed relationships and want to get pregnant this year. We're trying to make sure that you can dot your I's and cross your T's. We're doing that with the help of Dr. Paddy Ayete. Good afternoon, Nortey. Happy New Year to you. Please ask for me, if a pregnant woman feels some pains in the abdomen, what is the cause? Oh, Ajiman Joseph, right? In Committee 9, Jingo the man. Doc, any quick response to that? Though we are not.
It could be anything, and it could be anything. It could be the baby is trying to come out. This could be that she has a peptic ulcer problem. It could be that she's eating some bad unclean vegetables, and flagellates are worrying her, and so her stomach is cramping. There are so many different things that she could be going through all the time, and these are the simple ones.
Right.
It would be wiser that if she's got any pain that persists, she sees her doctor, he does an assessment, and based on what he finds, we'll be able to give her the right kind of treatment. Even the way you describe the pain tells us, give us a clue as to what it may be, and then appropriate intervention can be given for you.
Okay.
But staying at home may not be a good idea.
All right. Definitely see a professional, go to a facility and report the pain, describe it, and they will know what to do. All right. Thank you, Ajingo in Tema Community 9. You can send yours 055 11 11 997, Ultimate Health on Joy 99.7 FM. Our phone line is active 030 221 6541. Those are the healthy buttons to push 030 221 6541. We're looking at making sure, yes, that your vote will count. Whatever bullets you are firing, whatever the circumstance, will count, and your pregnancy will be achieved and will be safe and healthy. That's the important thing. Okay? So you can send your questions or call us. WhatsApp 055 11 11 997. Doc, coming back to you, what if I've recently had a termination or recently had a miscarriage? You know, whether intended or unintended. How long should I wait before I come to you and start this whole planning, the intent of getting pregnant again?
Or you can start, if it's for planning, you can come this month. You can come next month. You don't need to wait too long for the planning. But the planning process takes time.
Right.
And it will take us time to try and figure out, especially if you had a miscarriage. Why did you have the miscarriage? And there are various reasons why you have the miscarriage.
Right.
We'll ask certain questions.
Okay.
How did it happen? When did it happen? What happened first? What happened second? What happened third? Those details really give us clues as to what the cause of your miscarriage was.
Okay.
Without that, just, what happened? It just bled and that. It's not just bleeding. It is, how did it happen? Mm-hmm. What happened? Was there pain? Was there not pain? Was there cramp? Was there not cramping? Was there gush of water? Was there no gush of water? All of those tell us something.
Okay. So this
tells us an idea as to this is why you had that problem, and therefore these are the interventions we can put in place to prevent the next pregnancy from suffering the same fate.
Okay.
So going early when it's fresh in your mind, and also when we can actually intervene as early as possible is always a good idea. So that once your doctor has figured out what the problem was, you can put measures in place now. So that in 3 months' time, when we think everything is, settled down and back to normal, we can say, hey, try for another pregnancy.
Okay. Right. So if you've had any problems with pregnancy, termination, be it miscarriage, or even, should I say, a planned termination, an abortion, these are things that you should report and you should still present to a professional to evaluate your plans for getting pregnant again.
Excellent.
Okay. Good afternoon, Nortey. Happy New Year to you. Okay, I've read this one. This is Ajingo's WhatsApp. Let me see. I've got another one. It says it's from Nana or Nana. From Nana Kwesi. No. What does it say? What will you advise when a person in question is taking the risk factors for granted, especially when they are health practitioners who are supposed to know better? So if we have somebody who's taking these risk factors that may have been identified by you in this preconception consultation, they seem to be taking it for granted. What would you do? That's the question I'm getting there.
You can't do very much about somebody who doesn't care for their own life. A human being, and I'm saying this in all humility, a human being has the right to destroy himself.
Okay.
99.7 FM.
It's their personal choice.
Okay.
You can give as much counsel as you want, but until they decide that they value themselves enough to be able to make certain interventions, you can't do anything about it. The person must want to do it.
Okay.
And then, so our job, we give you information, we give you support for whatever decisions you are going to make, we give you encouragement. But at the end of the day, you have to decide and say, I want to take this step, and then certain resources can be made available to you.
Okay.
The same thing is about, people also talk about, you mentioned something about cost.
Yeah.
I have a philosophy. This body is the machine that makes the money.
99.7.
This body is the one that goes out and does the work, that generates the money, that looks after all the 10, 20, 15 people that you manage to look after. If you don't look after this body, how are you going to make the money to pay for all those things, people who you are looking after? It's really important, it's critical that you look after the money-making machine, your body.
Okay.
Because that is what determines. So when people are trying to do savings and scrimping, that I'll take a lower quality option because I'm trying to save money to spend on a funeral or something, or a party or a dress or whatever it is, I don't think they have their priorities, pretty right. But
Okay.
I can't do anything about it.
All right.
You respect their decision. You give them information. You hope that someday they actually come to the realization of the fact that they are actually more valuable than they think.
Okay.
And they need to do the necessary thing.
Right. With that mindset, it becomes an investment, not a cost.
No, certainly it's an investment. If I look at how much it costs me to service my car every 3 months, and I ask myself, do I spend that much on my health? The car, which is disposable, which every few years you change, we actually spend more on that, on preventive maintenance on the car,
Right.
than we spend on preventive maintenance on ourselves. Yet we are the ones that generate the money to buy the car.
Okay.
It doesn't make sense, but that is how we are.
Right. Okay. So that's important. Of course, the doctor cannot compel you or force you to, comply with the advice that they give, but they will give that nevertheless. Good afternoon, Nortey. How are you and your guest? My question is that why is it that when you take all the steps you need before conception, but first time your woman said, I am pregnant, you are still worried in yourself? This is from Hayford in Bato.
The unknown.
The unknown. Okay.
The unknown.
All right.
The unknown.
Okay. I have a caller on the line. Let me quickly take this call and come back to you for that response, Doc. Hello, good afternoon.
Yes, I hope you're doing well.
Right. Ajingo.
Yeah, a question just came in mind and I want to put it to you.
Hey, Ajingo. Are you pregnant? Share, please.
Well, sometimes clinically, there will be some tests with the man and the woman, both seems to be fertile. But at a point in time, they will tell you that both of them cannot give birth. Why is it the case? Why should it be like that? Like they will say that their blood doesn't meet in the local language.
Ajingo, why are you a lawyer? We've understood your question. Let me pass it to the doctor. All right. So, Doc, Ajingo is saying that is there something
I
compatibility? Some people, according to Ajingo, they are deemed to be fertile or in good health, reproductive wise, but they are told that they cannot, as a couple, have children.
Usually there is a problem. However, the truth be told that if a couple are trying to have a child and they are not successful, 40% of the time, it is purely the woman who has an issue. Another 40% of the time, it's purely the man who has an issue. And treating the woman is usually easier than treating the man. However, in 10% of the time, the man has an issue and the woman has an issue, so you have to treat both of them. But there's a 10%, 10 to 15%, that we cannot find the cause. It's what we call an unexplained infertility. I think when people talk about Omomoja and Shia, it's more of an expression rather than literal, that their bloods don't agree, because every blood group can pair with any other blood group when it comes to having a child. However, there may be something that just doesn't work. There are things that you discovered, something called anti-sperm antibodies, where there may be antibodies in the woman's vagina that may attack the sperm. But sometimes you can find a way to go around that if you can detect that. It's a pretty rare condition. It's not too common.
Right.
But there are some people it doesn't matter what you do. It just doesn't work.
Okay.
And those are what you call the unexplained.
Right. Okay. Thank you, Doc. Please, I have this sister who has miscarried about 4 pregnancies. What would you advise? It doesn't suggest that this person has seen a professional, but this is what the WhatsApp says.
No, she needs to see an obstetrician who specializes in this kind of condition. Recurrent pregnancy loss is a complex condition. One of the simplest methods, one of the commonest people who have it are people with polycystic ovarian syndrome. Those ones, the PCOS people, you can find a way to go around it. There's a way to go around it. However, those who don't have PCOS and have some autoimmune disorder or those kinds of things, oh Lord, it can be very, very challenging, because even finding out which of the conditions they have to try and give the right kind of treatment can be very challenging. So that is why it's best to see somebody who specializes in that, and that person will now take his time and, like a detective, try and figure out, is it this, eventually figure out something. Even some people have just got clotting problems, and just because of that, they'll have recurrent pregnancy losses. I mentioned autoimmune disorders. Some of them are quite simple. They are hormonal. The hormonal ones are easy to find out.
Okay.
You can find it out, give them treatment, and sort it out. But the autoimmune and all those odd clotting issues can be really challenging. But it's important that she works on that before her next pregnancy. The challenge with such people is that they'll come to you when she's already pregnant. There's no time to fix the problem.
Okay.
So invariably happens again. If they come to you before they get pregnant, you can then spend all your time working on the problem, fixing it, before you allow they actually get pregnant.
All right, great stuff. Is there something termed washing of the womb before one tries to conceive? If yes, what is this process? What does it mean? This is from Dede in Maryland.
No, there's no medical process called washing of the womb. It doesn't exist. There are certain procedures that are done that people try to describe it as you are going to wash the womb, but there's really nothing to wash. If the womb is doing a good job, it's doing a good job. It has a problem, the washing is not going to do very much for it in any way, shape, or form.
Okay.
If you have a polyp or a fibroid, the washing is not going to solve the problem. If you have blocked tubes, the washing is not going to solve the problem. Yeah, I mean, it's blocked, it's not going to open just because you are washing. Right. The only tiny benefits of introducing fluid inside there is, assuming there's a mucus plug, then because of the slight amount of pressure, the mucus plug may be displaced. So theoretically, those are the very, very small number of people that may benefit from, I wouldn't say washing the womb, but doing a tubal assessment. Because when you are doing a tubal assessment, because you put in fluid pressure, if it's a mucus plug, it may open the channel. But that whole process of you're going to wash the womb, it doesn't really do anything. Okay,
so whether that's some kind of colloquial or slang term, washing the womb, all sorts of hocus pocus, should I say, done under the guise of clearing you and making sure that you are able to conceive. Doc says he's not aware of any such process or procedure. See the right persons, see a qualified person, and therefore you will know you are on the right track. This person comes back, the person who says, what if your partner refuses all the information and advice? Doc, if the person in question is my partner, to which every decision made will affect me, either negatively or positively, how can I not care whether he or she is taking it for granted? If they are playing solo, cool. So advise me, the partner who is dealing with, and I don't advise me, the partner who's dealing with it, and not the spouse. So this has to do with, failing to heed.
So now for the spouse, you have. The advice you need is outside my scope of expertise. You've now entered a relationship issue. It is always very challenging when you have a partner who is persisting in dangerous conduct. It's difficult to advise somebody who is addicted to particular drugs that I need you. This is the impact it's having on us, and therefore they should change. The addiction is stronger. It's difficult to advise somebody who has decided that I'm not going to follow advice, even though I've been given all the information that shows that this is what is good for me.
Right.
They still persist in that action. You need to speak to somebody who can give you the appropriate counsel. And the amount of information that they need is a lot more than you can give me on this program as to how you should handle it. For some people, there are ways that you can arrange for some kind of what's the word for it? It's not confrontation. There's a word for it. Nortey, you should know it. You're familiar with it.
Well,
where they bring people to come and meet you at a particular point, and then
those are mediatory processes.
They face you with your problem.
Yeah.
And then you have to decide that I'm going to intervene, I'm going to accept the intervention, or I'm not going to do it at all.
Exactly.
You may, at some point, you may have to go through that process.
Right.
For some people, they just will not be willing to accept. And then you have to decide as to whether you think the relationship is worthwhile or not.
That relationship is patent.
But you need to speak to the right person.
Right. Okay. Now, Doc, that quickly brings that. Let me just say hi to Sarah Manful in Winneba. Right. She says Happy New Year to us and the Ultimate Health team. Thank you, Sarah, for tuning in. If you've just joined us, we're not out of time yet. We still got Dr. Paddy Ayete. We've been looking at preconception consultation, how to make sure you successfully get pregnant this year, 2025, the do's and don'ts, what to look out for, and what essentially comprises or is undertaken during a preconception consultation. Somebody's sending something about the washing of the womb. It says scroll. This washing of the womb thing, what successfully formed? Ajiman Joseph again, right? Okay. I'm not too sure what he means, but he wants a take on that. Good afternoon. Please tell Dr. Adumako of Coco Clinic that baby is in after 7 long years. Getting pregnant is not easy, as we see. May God grant all potential mothers and fathers fruit of the womb. I had to wait for 7 years after being told we are both fine medically. God help us. This is from Frank Inteshi. Doc, any comments on that?
Frank Inteshi, congratulations. God has come through for you. And I am delighted that you have gotten the baby and you persisted. And it's a lot of people give up along the line.
Yep.
You persisted and you are reaping the reward of your persistence, and we thank God for your blessing. Please, hurry up. What you did, do it again so that you can have another baby very quickly. Don't tell me that I'm waiting for this one to grow. No, 3 months, when the baby is 3 months, no, start trying again before it leaves your system, so that if God gives us favor, we shall have another child. Frank. If you have 2 children and they are 1 year apart, we will not get angry.
Frank, Doctor said to us. All right, that's good. But Doc, we've tiptoed into the mental well-being of the person who plans to get pregnant. You and I know that this is an important area. Does it feature, is it emphasized in preconception counseling or consultation? If I'm not mentally well, I'm unstable, or there are many other mental health issues that are identified and significant in this, should I say, endeavor, right? This enterprise to get pregnant, is it emphasized in preconception consultation?
Yes, it is. Remember when I was talking about pre-existing disease and I mentioned diabetes and depression as one of the conditions?
Right.
When we are looking at your history, we are looking at if you have any history of such mental illness, if anybody in your family has any such history of such mental illness. Okay. And if you are the primary caregiver of the client, by now you have a fair assessment of their mental health and see if there's any changes since the last time you saw them. But in your discussion, you are judging them to make sure you really think this is a good candidate and this is somebody that will be able to carry a pregnancy. Because we are worried about exacerbation of mental health disorders when they are pregnant.
Okay.
Because there are limitations in the kind of medications that we can give to you. Then you have those who, after they deliver, have postpartum depression. Right. And some of them can be really bad. You can actually go into proper psychosis. So if before you get pregnant, you discover that you are not mentally stable, we will rather have you seek the right kind of attention so that you are mentally stable before you actually get pregnant.
Okay.
It's important for the health of that child. Children have been neglected. Children have been killed just because the mother was not mentally well. And after, subsequently, when she got well, she was profound regret, and actually make the mental disorder even worse.
Right.
Because she now realizes the fact that this is what she has done.
Okay. So this is a component of preconception consultation, and if the doctor is unable to, should I say, evaluate this properly, I do believe the appropriate referrals will be made.
Yes.
Okay. Right. Doc, I'm going to quickly ask a few questions. I know we hope to give out some kind of checklist, but folks, you can Google preconception consultation. It will give you the list of things and areas that will be covered: your medical history, your family history, lifestyle, and many other things are listed in there. But Doc, let me ask you, it may seem, and perhaps genuinely so, that our discussion seems to be focused on normal conception, normal ways and modes of getting pregnant and having a child. If it were the case that this is somebody who is considering assisted reproductive technologies or strategies, other ways of conceiving, would they still go through this process of preconception consultation, knowing full well that, well, in those other ways, IVF and ICSI and all those things, it's people, qualified persons like you who are making things happen. Do I still need to go through preconception consultation?
Oh yes, you would. But it's actually integrated in part of the preparation that we do for the IVF. So there are lots of tests that you run before you do an IVF on a patient, and you're looking for those problems inside.
Okay.
In their reproductive history, you're asking questions as to if they haven't gotten pregnant, why they haven't gotten pregnant. They tell you their story. You ask questions about their siblings, how many children they have, when they had menopause, if they've had menopause, when did your mother have menopause, are they this kind of disease in your family, diabetes in your family, hypertension, tuberculosis, sickle cell. We are asking all those questions. A lot of these questions are part of the process when we are doing the preconception studies. Okay. And therefore, it's actually easier when you're coming from like an IVF or things of that sort, because we ask most of these questions routinely in the assessment before you actually do the procedure. And so it's easier. But for those who are trying to conceive by themselves, they are the ones who, an IVF client has decided that I want to get pregnant and then comes to the hospital. Those who are trying to conceive by themselves usually may not have taken that step. That I decide that I want to get pregnant, and therefore they are the ones who are more likely not to have a preconception visit.
Okay, right. Now, Doc, it takes two to tango, if I can use that phrase, right? It takes two to tango. So, yes, some of the tests, some of the preconception consultation focuses on the man, some focuses on the woman, and so on and so forth. Mm-hmm. If you have one half of this unit, can you still go ahead? And if you reach the stage that I assume that you will require the other partner to present themselves before this process, and there's a challenge there, what is the arrangement? Can you literally issue a habeas corpus or a mandamus and say, go and bring the man, or bring the, what do you do in circumstances where you don't have an intact unit or couple?
You work with the partner that you have.
You work with the partner that you have.
You work with the willing.
Okay.
The one that has come. You work with the willing.
Okay.
You will try and encourage the other one to come. You would sometimes try and make it easier for them. It's like, okay, if you have a questionnaire, you can give to the one who has come and say, when you go home, we need to know the following things. Is he willing to fill it out? Or here's the lab test that we need done. Can he do it and give you the results to bring? Right. We do that especially for the sperm. We tell the lady, you collect it and bring it. We take it like that.
She should collect the sample.
She should collect the sample in a bottle and she should bring it.
Okay.
If the man doesn't want to step there, you collect the sample and bring it. We work with what we have. Oh. But sometimes we just do that to make it easier for us to achieve our objective.
All right.
But sometimes the person would come and the other partner is just not interested or not willing. You work with the one you have, because the one you have may have problems that you need to fix.
Right.
And the other one may or may not have problems. Right. So you just work with the one that you have, and over time, the other one may be convinced to come,
right,
or the relationship may end, and then she may start with a new relationship. I've got occasions where the man will come, but the woman will not come.
Right.
I've got occasions where the woman will come, but the man, you never even see the man.
Okay.
So we just work with the one that we have, and
all right, it's a starting point.
Optimize that one.
Okay.
Because
great.
That's a serious one. Yeah.
Okay. Amma from Adabraka says, let me just click. Hopefully one day you'll discuss menopause in women. Amma from Adabraka. Well, if you're a loyal listener, you know we've done that. We will be touching on many of these things, okay? There's a whole spectrum of things we have to discuss in this Conception 2025 series. Assisted reproduction, all the surrogacy, adoption, the different IVFs, ICSI, all those things, the mental health, psychological issues related, and, miscarriage, a whole lot. We hope, Ziggy and I hope to deliver on this promise. We are pregnant with ideas and topics. So menopause will come in. All right. Doc, so let's just, we're running out of time, but when this has been successfully done, okay, let me just quickly read a few of these. Dede in Maryland says, family history, ? Is there such a thing in our part of the world where any and everything is hidden, embedded, and never talked about? Can you really properly elicit family history? And will people willingly disclose these things in such a process, Doc?
Yes and no. For those who really want assistance, there are two people you shouldn't lie to: your doctor and your lawyer.
Okay.
For those who really want assistance,
so you can lie to your pastor.
People lie to their pastor.
All right. Okay. Amen. Please go ahead, Doc.
But you should you should if you really want to be helped. Mm-hmm. You need to say what it is that is bothering you.
Okay, right.
And if you know this phenomenon occurs in your family, you deal with it.
Okay, right. So you should
because think about it like if you've got mental illness in your family and you know it exists, then it's one of the things that we should be looking at. Is it transmittable? It's not transmittable. Is it genetic? Is it this? Is it that?
Okay.
We talk about it. We figure it out.
Right.
If you have sickle cell and you are trying to hide it, you are the one who have the SF child. Mm-hmm. If your family has bad hypertension, you are the one that may not succeed in having a pregnancy go to the end. Right. If you don't say that, hey, you are okay, you had hypertension before, that's under control.
Okay.
Or you stop taking your medication for whatever reason it is. Especially for the men, when they are having erection problems, then they stop taking the medication.
Mm. Okay.
Having a stroke is no fun. We are better off fixing the problem rather than having the stroke.
Right.
So those are the kind of things that we really need to address.
Serious stuff.
As aggressively as possible.
Okay. Doc, after all these things have been done, I see a lot of potential and well-validated referrals and investigations, examination, and all sorts. But after all this is done in the pre-conception mode, is it the case that, the follow-ups will be done, any fixing or intervention that needs to be done for some identified conditions and risk factors will be done? What happens after you've gone through most of these things? Are you given let me put it this way. Are you given a green light, a thumbs up by the doctor? Frank Inteshi says your advice is taken, so I'm sure this evening something will be happening. you said he shouldn't.
Sorry, I apologize in advance.
Okay, you said he shouldn't wait. But in terms of this preconception consultation, is there a point in time when you say, okay, we're good to go, go get at it and get it done?
Yes. At some point in time, you're like, you've checked everything is good. We are like going to get pregnant. If there are things that we have to correct, you've got your blood pressure under control, your sugars under control, all your labs and things show that everything is fine, we are like going to get pregnant.
Okay.
And we tell you have sex three times a week. That part is important.
Right.
But vaginal intercourse 3 times a week.
Okay.
Ejaculation in the vagina, and we shall we are looking forward to a pregnancy.
Okay.
You have a 20% chance of getting pregnant every month. So every month, 1 in 5 will get pregnant. Keep trying.
Right.
Your number will come up.
Okay. If the partner is known as Arsenal or Chelsea, are you the coach or the manager in this case? Because you want them to do certain things. They have their part to do, and you, the professional, the doctor, the specialist, have your part to play.
Yes. They are the coach. You have to get them to do what needs to be done.
Okay. Doc, we've crossed over our closing point, but let me quickly ask you this. If I wanted to register with a physician, a professional, a facility, and go check and declare my intention to get pregnant, is there a registration process? Do I just pop into your clinic and say hi? What do you do?
Pop into okay, so first of all, everybody should have their own primary care provider.
You should have a primary care
Yes,
provider.
if you have your primary care provider, you can go to your primary care provider and say, hey, this is what I've been thinking about. How can I prepare for it?
Okay.
Done. It's okay. Not a problem.
Okay.
In the event that you don't have a primary care provider, then at this point in time, you can find somebody.
Right.
Typically, if you find the doctor you intend to continue your care with, as okay, I intend to get pregnant and I would like to continue have my pregnancy looked after by this doctor, go to that doctor. Let him start the process for you.
Okay.
Because he has to manage the problems when they arise.
Right.
But if you have a primary care provider, go to your primary care provider because he has to coordinate all your doctors. The idea is that your primary care provider coordinates with all the various doctors that you are going to have to interact with, the specialists that you can interact with.
Right.
So you do that in conjunction with your primary care provider, and we should be able to be seen.
Okay, Doc. So
you can walk straight in. I mean, book an appointment, go in. Why are you here to see us today? I intend to get pregnant, and so I'm coming for a checkup.
Okay.
Patients do that to me all the time.
All right.
New patients, yeah.
Okay. So they are registered or identified as a patient. It's not that you are in the preconception class and you go.
No, you
go for lectures.
Patient,
You're not going for lectures and stuff like that. You won't be giving homework.
No.
All right. And there was the last thing I wanted to ask. Many people do ask this because in our parts of the world, of course, there are many beliefs and other things, but cost is an issue. Preconception, I'm not pregnant, but I am going through many detailed evaluations and assessments which will allow the provider to determine the viability of the whole enterprise, the whole journey. Are we able to put any ballpark figure on these kinds of things?
No. All depends on what you find. For some people, it's after asking questions, you are pretty okay with where they are. Maybe they've had some tests that recently you can look at. For some other people, there are things that you really need to investigate. You have no idea how much it's going to cost.
Okay. Doc, I'm a man listening today. I typically will hear that you're a consultant, obstetrician, gynecologist. Can I walk in there, womanless, so to speak?
And they do it. I see men all the time.
Men
they just walk in and say, hey, I've done a sperm test and there's a problem. Some of them come with their erection problem and things.
Okay.
Even though I'm not a urologist. But a lot of men just walk in and say, I have this challenge and I'd like it dealt with.
Okay.
And so we do the investigations and find out what the problem is and start giving them solutions to try and address it.
Okay. Some
and then quite a number of them actually get pregnant. Right. Actually, some of them, after coming for a while, then the wife will be willing to visit.
Okay. Right. Yeah. So male, females alike should be relieved at this whole concept of preconception consultation. We've tried to unpack it. There are many, many, many areas. Your health, pre-existing conditions, chronic illnesses, infections, your weight, lifestyle, diet, whether you exercise or not. All of these things will go into that ballot box. And Dr. Aye or any other similarly qualified professional will be the returning officer who will now be able to guide you and see whether this is possible in 2025. As part of this spectrum, this series, we will be looking out for certain, should I say, presentations. We will assist or try to assist and point these people in the right direction. But when there's a goal scored, we'll know where to identify.
I'll announce it.
Yes. Doc and I and any other professional will be what identified as giving an assist. That's what they say in the Premier.
Yes,
in
an
football,
assist.
an assist. Not Ato and his people will say it's an assist. We will assist. All right. We are not going to guarantee that you will get pregnant, but we're going to make sure that you're pretty close to success. Doc, any other things you want to say with this regard to this enterprise of achieving conception in 2025?
No. We've spoken quite about this at length. Hopefully, we'll have time to talk about the methods by which they can actually get pregnant.
Okay.
Because now they prepared it. Now we can then talk about how they can get pregnant and the kind of problems that they need to fix if they intend to get pregnant. But, I think you've done a pretty good job.
Right.
Thank you very much.
We couldn't have done it without you, Doc. And, thumbs up to you guys at Elimas and all the other professionals we work with in delivering ultimate health. In the series, we'll speak to embryologists, we'll speak to consultants, obstetricians, gynecologists, nurses, you name it, the whole spectrum. And like Doc just said, we'll consider the different methods that are available. Yes, surrogacy is available in Ghana, ICSI, IVF, and many of the other things are available. Somebody wants to know when the cervical cancer awareness month starts. I do believe some facilities have started already. We'll get stuck in there pretty soon, okay? She's saying she hasn't heard anything from Joy FM. Yes, we'll do it on Ultimate Health pretty shortly, all right? But many of the health facilities are offering screening, and sometimes they do give discounts. But again, consider it an investment and not a cost. Once again, many thanks to Dr. Paddy Ayete, consultant obstetrician gynecologist, specialist in minimally invasive surgery. He's a fertility specialist as well, and he's the CEO, medical director of Elimas. They're at airport. Take a left if you're coming from the Gold House. Take a left after the National Service Secretariat. You can find them. And of course, Block Factory Junction, Committee 18, you can find Elimas. There are many other providers, and many of the health facilities can help you kickstart that process. Once again, many thanks to my producer, Ziggy Bedu, for all the help and connection and all he did to make sure that our phone lines, our X, our YouTube, and all those things were fertile. They can stay on Joy 99.7 FM.
Joy 99.7 FM.